life, life as an ophthalmologist, and also the application route and what it will mean to apply to ophthalmology, how you do it, what kind of sort of portfolio you need to put together. And just for my own knowledge, I'm just going to have a look at everyone who's in the chat. Maybe okay, great. Okay. Um, if whoever's able to pop their cameras on, I would appreciate if you could, because I just want to see sort of a raise of hands. The level of you guys at the moment, are most of you medical students or sort of foundation year doctors? What's the level I'm pitching to? So if you wouldn't mind turning your cameras on, if you just raise your hand if you're a medical student, so I've just got an idea. Or you can raise your hand in the chat, whichever one you prefer. So at least one. Okay. So a few medical students. So is anyone here a foundation doctor, or is everyone medical students? Fine. So what I'll do is I'll pitch this in such a way that if you're a medical student or more senior medical student, or if you're foundation doctor, what sort of steps do you need to take at the moment if you're interested in a career in ophthalmology? So I'll just give you a little bit of background about myself. So I'm a University of Nottingham graduate, finished in 2018. I did my elective over in Nepal in ophthalmology at the end of my medical school career, and then I went down to London for my foundation training, and I was lucky enough to get my training number straight out of F2 into the West Midlands, where I've been working up until now. So I've been there for the last 3.5, almost 4 years now, doing my ophthalmology training. This picture over here you see is a picture of one of the waiting rooms in Nepal in one of their eye casualties, and it doesn't look too dissimilar to what most British eye casualties are looking like these days. So it is a busy specialty. What is an ophthalmologist? So essentially, it's a subspecialty of qualified doctors involved in the diagnosis and treatment of eye conditions. So quite a simple sort of thing at its core. It's a clinical medical and a surgical specialty at the core of it. So there is a component of both involved in your day-to-day work. You're addressing primary ophthalmic conditions, things that might be coming in as a sort of a front door sort of thing, i.e., like an eye casualty, or you'll be involved in the specialist care of patients with complex eye conditions. So these pictures you see at the bottom, you've got someone being examined on a slit lamp. This is a day-to-day examination instrument that you become very familiar with as an ophthalmologist. Over here, in the middle, you've got someone examining with an indirect ophthalmoscope, which might be used on a ward setting, on a community setting where you don't have a slit lamp. And over on the far right, you have a intraoperative picture of someone having cataract surgery. So to remind you that it is a surgical specialty at the core. A typical working week for an ophthalmologist. So this is roughly what I'm doing at the moment. So it's very much an outpatient-based specialty. You've got very little ward commitment most of the time, which means you spend most of your times in clinics or in theatres. So my Mondays, I normally operate in the morning and I do a clinic in the afternoon. Tuesdays, I typically do a laser clinic in the morning and I'm in eye casualty in the afternoon. And then the remaining days are a combination of either subspecialty clinics, research sessions, or operating in the operating theatre. In addition to this, we'll be doing on calls, so you'll have an on-call commitment as well, where you'll be staying late after work to see patients in the eye casualty and also be on call for the region for any emergency ophthalmic issues that might arise that you might need to advise on or see out of hours. And this is a typical rota for an ophthalmology trainee. This is actually my current sort of rota that I'm working on at the moment. The big thing to know is that I'm working 8:30 to 5:30 job, sort of day job, these red squares over here. And once a week, these pink slots over here are your on calls. So you'll be working a non-resident 24-hour shift once a week. And then you'll have some weekend commitments as well, which is what these green green areas are. So one set of weekends every 8 to 9 weeks is what we do at the moment. What are the pros and cons of ophthalmology? So this is something that you would have to have a good think about yourself if you want to apply naturally with this, as with any other subspecialty within medicine. So the pros of ophthalmology is that number one, it's a run-through training program. So there's none of this application into a intermediate or core training program and then re-application into a higher registrar training program afterwards. So you cut out one of the interviews and one of the applications or cycles. So once you get in, it's a straight road to consultancy if you can keep up with the requirements required of you. There are supportive seniors within ophthalmology, and particularly in theatre, it's very much one-to-one training, which often gets neglected in other subspecialties where you have a lot of different sort of work commitments that might not mean you get one-to-one training with a senior. It is a medical and a surgical specialty, which means that you get a sort of best of both worlds. But it also means that if you're not particularly surgically inclined at the end of training, you can give up surgery and focus on medical ophthalmology alone, though you would be required to show some surgical competency during your training. The on-call requirements generally as an ophthalmologist are less aggressive compared to other medical and surgical subspecialties. I say less aggressive because we often don't do resident night shifts. But having said that, the times that we are in work are always hectic, so you just have to bear that in mind. For most of ophthalmology, it's a quality of life specialty rather than a limb or life-saving surgery sort of specialty. So you often have grateful patients actually, which is quite a nice thing. Within the specialty, you've got a massive amount of variety. And you think, how much variety can there be in an eyeball? But actually, there's 9 major subspecialties within ophthalmology that you can subspecialize into, all with their own different medical and surgical components that you'd have to learn in depth. Something that gets talked about a lot about ophthalmology is a thriving independent or private sector, which becomes available to you once you become a consultant. And it's becoming more and more prevalent and more part of the working life of most specialists once they qualify with the state of the NHS at the moment. That's not to say that there is no independent sector in any other specialties. Of course, there is, but ophthalmology also has a thriving sector that you can become involved in. And for me, the fact that we almost never have to step onto a ward was one of the more enticing reasons to choose the specialty, having had a pretty rough foundation year 1 and year 2 training. Now, everything has cons. Ophthalmology certainly has its own specific cons that you need to be aware of. So the first thing is that the learning curve is really quite steep. You're learning a completely different language within medicine that you wouldn't have much of exposure to, particularly during medical school or any time during your foundation training, unless you do an ophthalmology job. The exams are hard, and they are very much thresholding exams. So the first set of exams are harder than the second set, which are harder than the third set. So you really have to put in the time and effort right from the beginning to clear these exams. Within the NHS, surgical training opportunity is going down. That's been a downward trend ever since COVID. So as a trainee, we are constantly having to fight for our surgical sessions and to fight for our surgical numbers, to the point now where we are being sent to the independent sector to operate because the NHS hospitals can no longer provide us with adequate training numbers. This is a trend across the entire surgical field, not just in ophthalmology, but it's something to bear in mind that you have to fight hard for your own training in a lot of these situations. It's highly competitive at every stage, not just at the point of applying and getting into the specialty, but then within the specialty, applying for certain jobs or rotations or TSCs or fellowships or consultant posts. So it's a small specialty. They only admit something like 80 to 90 new trainees every year, and you will be constantly fighting for a small pool of consultant jobs at the end of it. So it's a long haul in that regard. So you always have to keep on top of things. I found that having been very much at my peak of general medicine, I forgot things very quickly, and that happens whenever you go into a subspecialty. But ophthalmology is so far removed from general medicine that you forget it very quickly. Um, but equally, having said that, no one apart from ophthalmologists know a huge amount about eyes. So you end up in a situation where you've got poor referrals going both ways. Either you are receiving a referral from a doctor who can't tell you much, and you are referring a patient from your side to the medics or the surgeons who you can't tell them very much. So there's a little bit of frustration going both ways. And keeping on top of this knowledge becomes increasingly difficult the more senior you get. Um, as I mentioned, it's an outpatient specialty, but that means that your clinics are always rammed, and as is eye casualty. So it's extremely busy outpatient specialty. It is the busiest NHS outpatient specialty. 10% of all outpatient appointments are ophthalmology. So imagine that for a specialty that only admits 80 to 90 new trainees every year, taking on 10% of all of the NHS outpatients. So it can get quite hectic at times. Even amongst medics, the eye makes them shudder. People get quite squeamish around the eye. The concept of operating on an eye can be quite, quite put off. But I imagine if you're joining the school, you have some interest at least. And when you're looking down a microscope at an eye, you tend to forget all that anyway. And something more of a philosophical thing, which is this is lifestyle medicine. This is sight saving. It's rarely life saving unless you're picking up serious systemic disease via a first presentation from an ophthalmic presentation. And people often call us eye dentists for this reason. So if you can't put up with that, then it's probably not the specialty for you. So for those of you who are not aware of things work, so primarily looking at medical students in the chat, this is how subspecialty training works in the UK. You'll finish your medical school, you will start your FY 1 year, after which you complete your F1 year, you get your full registration with the GMC, and then you're required to do your foundation year 2 training. If you go through to a run-through specialty program, such as ophthalmology, you would apply directly into the specialty and you'd be doing that specialty alone for the remainder of your training, which can be anywhere up to 8 years. But if you're doing something like GP, that'll be in the region of 3 to 4 years. You'll then get your CCT and become a consultant. And you may then choose to do a further 1 to 2 years of fellowship training after your CCT before taking on a full-time consultant job. In contrast, if for example, you want to be a cardiologist or a respiratory physician, you would go into your IMT training, a core training program for anywhere up to 3 years, and then apply into a higher registrar training post afterwards. So there's a gap here where you had to reapply into training. So that's the difference between specialties such as ophthalmology and say radiology, which are run through training programs, compared to other specialties. And ophthalmology is competitive. There's no two ways of putting that, and it's been getting increasingly competitive year by year. I applied and got in 2020 when things were starting to ramp up. It was close to a 6-to-1 competition ratio at that point, but in the last round, it has been close to 10-to-1. And there's several reasons for that. I mean, the number of applicants has doubled over the course of those 3 or 4 years. There is a larger bottleneck of doctors being caught by highly competitive specialty programs and applying again year on year. So these numbers are going up, and also the fact that training numbers haven't really increased to compensate for those numbers. I imagine people also want to apply for ophthalmology for a number of the reasons that we mentioned. It's fairly nice in terms of lifestyle. It's got a good mix of surgery and medicine, and good independent sector prospects once you've finished your consultancy. So there's a lot of reasons why this number is going up year on year, which means it's even more imperative year on year that you're able to make yourself stand out from this crowd of 971 applicants to be the one of the 98 who can get a post. So what I'll do for the remaining talk is give you an idea of how to get those points and what you need to be doing now to start making this happen. So it's all about gaming the system. You don't have to be a professor of ophthalmology to get into an SD1 post, however much people might tell you that. If you can game the system, work out where the points are, work out what you have and what is achievable for you in a realistic time period, you can get into the specialty. This is coming from someone who managed to get in directly after F2, so I didn't take any years out after my foundation to do sort of F3, F4 year to prepare a portfolio. And I knew I wanted to do ophthalmology probably towards the end of med school, that sort of time period, which is not unusual for a lot of people. But even if you decide a little bit later on, you still have time to sort of put a portfolio together. As you can see from the points breakdown, the portfolio is the biggest component that you're tested on. So half of your points will come from your portfolio. 30% will come from an online interview and 20% from the multi-specialty recruitment assessment, which is a key sort of component that you need to be able to advance through in order to succeed in this application process. So I'll start with the MSRA because it's the first hurdle that you will have to cross in order to even get your foot in the door. So what it is, it's a prerequisite for your interview. So you have to sit the exam and score well enough to even progress far enough to get the interview. And there's a threshold mark. So for all the people who apply, only the top 300 candidates in the MSRA will be invited, not even for an interview, just to submit their portfolio. Okay, so you have to score well in this exam. It's 2 papers lasting that long. There's a professional dilemma section, which is analogous to the SJT. Now, for the medical students, and I think any foundation year 1 doctors, that's probably all going to change for you because when we finished med school, we had to sit our SJT assessment, situational judgment test, and that formed part of how we were allocated to foundation programs. But I understand that's all sort of changed now and you sort of end up on a random number generator or something. But essentially, the MSRI uses an SJT component. So you'll be given ethical scenarios and you have to rank the responses based on how appropriate they are, and you get marked on that. Very difficult to prepare for, not impossible to prepare for. You can game it if you know what the sort of how the question is framed and what they expect you to answer, basically. The second section is a clinical problem solving section, which is basically your clinical knowledge. Now, the MSRA has historically been a GP exam, so that's where it originated. So the questions that you're asked in this are very much at the level of a primary care physician working in a general practice, but the scope of the questions is broad, as would be what you would expect in a general practice. So you'd be asked everything from medicine to surgery to obstetrics to gynecology to pediatrics to ophthalmology to ENT to dermatology. Everything will be asked of you, and you'll need to know it well enough to score well in the exam. It's almost analogous to your med school finals, except the level is slightly different at a more sort of generalist level. And a lot of our specialties are being subjected to this exam now. So whether you want to do radiology or pediatrics or psychiatry or neurosurgery, or ophthalmology for this case, you have to sit this exam. So lots of people will be sitting it. Now, the portfolio itself, this is your next hurdle. So there are 8 subheadings, each of which I'll go through with you in a bit of detail, so you know in your head mentally what you need to have prepared into display portfolio. You get how well you present it. Max points, like I said, 50. Typically, 2 consultants will review your portfolio and each give their own individual mark to give a total mark out of 100. And this is the focus for the next few years to get a good portfolio up to scratch. Everything that I'm going to talk about is on the Seven Deanery website. So Seven Deanery coordinate the national recruitment at ST1 level for ophthalmology. So everything I'm going to talk about is directly lifted from their website. So there's no need to screenshot or take photographs or anything like that. It'll all be on the website. So all you have to do is Google ophthalmology ST1. It's the first thing that comes up. So the first thing you'll be asking your portfolio is what qualifications do you have? These are essentially degrees. Now, they have tightened everything up in the portfolio since I applied anyway 3 years ago. And they've made it more difficult to score points. So now you get a point per qualification. So if you've got a master's degree, if you've got a bachelor's degree, you get a point. If you've got an MD, which is unlikely, you'll get 3 points. If you've done your PhD, you'll get 4 points. So you don't even get full marks for having a PhD. Now, importantly, they don't accept intercalated degrees now as a point on your portfolio, which I think is quite harsh. Certainly, a lot of us got a point there. So only if you've done a separate degree from medicine, not an intercalated degree, do you get that point. This is basically to award a lot of the optometrists who apply into medicine and then become ophthalmologists. They get that point there for having their optometry degree. Now, prizes and awards is the next section where you get 5 points maximum. If you've sat the FRC Opt exam part 1 and you've scored first place in the entire country, you get 3 points, which is, unrealistic. If you scored a first in your undergrad degree, so if you've got an honours or a distinction on your medical degree, that's a couple of points, which is, I think, for some people, a possibility. The thing that the medical students can do now is the Duke Elder. So the Duke Elder Prize, if you get in your top 10% on the Duke Elder Prize, you get 2 points. And if anything else, you get sort of half a point, 1 point, that sort of thing. Wherever you present in your national, regional, international meetings, if you've got a best poster or presentation, a prize there's points available for that. And if you're into your research and you've been granted a research grant application, then there are points for that as well. What for the foundation doctors, if they've awarded you some sort of prize in your foundation, so best portfolio or best F1 in your hospital or whatever, then those sort of things counts for a few points here and there. But again, a difficult section to score points in, and not something you can do unless you're exceptional, or you've put a lot of time and effort into it. This is where you're going to score most points. So this is the ophthalmology specialty links, basically your commitment to specialty section. And a lot of these points are achievable at a medical school or a foundation doctor level. Now, the first two on here, which are the refraction certificate and your FRC Opt Part 1 examination, are challenging things to do. There are more and more foundation doctors sitting FRC Opt Part 1 and passing, but that is a 6-month commitment of time and effort and not a guaranteed pass because it is a hard exam. So I would only say to do these things if you've already maxed out the rest of these things, which are much more achievable in a limited time. So if you've got things like a non-peer-reviewed publication or case report, so if you've got a case report in ophthalmology, you can get points for that. If you've done an ophthalmology elective, so med students, you get 2 points for that. If you've done a taster week, so foundation doctors, you get a point. If you've used the eyesight is a cataract simulator, and they have them scattered around the country. So there's one at the Royal College of Ophthalmologists in London. We've got 2 in the West Midlands. So you have to find out in your region, where is the eyesight? How do you get access to it? And you have to log 4 hours of time on the eyesight in order to get a point, and that's achievable. This one, evidence of ophthalmology simulation training, I think that's a challenging thing to do as a foundation doctor where you're not involved in ophthalmology unless you're doing an ophthalmology foundation job. So have a think about that. It might not be achievable for most. This one is achievable, attending ophthalmology theatres and clinics. You have to get 10 sessions signed off to get this point, and it has to be done outside of your taster week, and it has to be done over more than a 3-month period. So that you have to show sort of continued attendance over the course of 3 months or more to show that you're committed to the specialty. But that is achievable. And then you get up to 3 points for attending conferences and meetings and things like that. So again, it's kind of a buying points situation here, because if you can just pay lots of money and go to conferences and get your points that way as well. But if you're smart about it and you're able to get yourself a poster together or a case report, submit it to a conference, get that money paid through your study leave, then you've got a way of generating points at no cost to yourself. They also talk about this discretionary 2 points. If you've done something extra that doesn't fit these categories and you stick it in the ophthalmology specialty links, the consultant looking at it might say, oh, that's pretty nice. You get a point or 2 points or whatever. So this is where you can score most of the points. Now, when you're a foundation trainee, you'll be asked to provide multi-source feedback. So you'll go around and you ask your nurses, your ward clerks, your receptionists, your other doctors, whatever, was I a good doctor? What sort of feedback would you be able to give me? And you have to submit that on your portfolio. Now, that gets scored, and in the past it was always a mystery how they scored this, but now they've given specific sort of ways and how they score it. Basically, if you want to score maximum points, it has to be the most glowing, amazing report ever. This is the best training I've ever worked with. No one could level, the aptitude of this particular trainee and this and that. So again, most trainees aren't going to get this sort of thing unless you really sort of push for it and ask for it, which may be seen as being a bit cheeky. One thing I found very useful in this is asking people to mention you by name. So Adam was such and such, Adam was such and such, rather than sort of generic comments, and you can get more points that way. Now, if you're published, there are points available for that, up to 6. If you're a first author, then you get 3 points on your publication. If you're anything less than first author, you get a point. If you're below fourth author, no points. So if you've got 2 first name author publications in a peer review journal, you max out your points already. Okay. Again, I applied with no publications, managed to get in. So it's not an impossibility, but something to think about. If you've got research, material brewing somewhere, and you can get it published somewhere, get on it and get it done, because it will only help you. Quality improvement and audit, they're pretty hot on this, and you must submit something for this, otherwise you're wasting your time. It's a best audit, so it's a single audit that you've done in the last 3 years, not all of the audits you've done. You have to provide a cover letter with your consultant signature to say that you've done this audit, you were the lead, you did this, and this, and signed by the consultant to say that you did it. Okay. And you also need to give proof of presentation of the audit, so that you've finished the audit and you've presented it at least at a local level to say that that you've done something about it. These are how they score the audit. To get full marks, you need to have published your audit or a guideline and then implemented your results in a regional or a out of region manner. So that's, again, pretty unrealistic for most people. But what is realistic is at least 3 points. Being in charge of the audit and implementing. And if you complete the loop and implement the change, that's 4 points. So that's pretty reasonable and achievable for most people. Presentations. So these are your poster presentations and your sort of oral presentations at meetings. Basically, a point for a regional presentation, 2 points for a national presentation, 3 points for an international meeting, up to 6 points. So this is where you can capitalize on whatever audits or research you've done, presented at a meeting, do an oral presentation, breakout session, whatever, or submit a poster, get your best poster prize if you can, and then you've got your ticking boxes here and there with one good project, rather than having to do lots of little things. And that's how you can capitalize on this. Education and teaching, always on the ophthalmology portfolio as one of the more unrealistic things to achieve, because the kind of things they ask you to do is ridiculous. To get 3 points, they want you to write a postgraduate level academic book, literally a book. So most people are not going to be at that level. The things that you can do are helping with educational courses, doing an e-learning tool, doing teaching the teachers course, that sort of thing. So you get a few points, scatter a few points here and there for that. Um, if you've got a PG cert, that's a couple of points. But again, it's not something that I would personally say go out of your way to spend a year and a lot of money to do a PG cert just to get into ophthalmology. But if you have an interest anyway and you want to do it anyway, then that's something that's possible. And with a few bits here and there, you can achieve sort of full 5 marks. And this is pretty key. So you get 3 points. That's 6% of all your marks just on how you lay out your portfolio and how its quality and how it looks. So if it's neat, if it's organized, if it's easy to go through, if it's not overcrowded by superfluous evidence that is not required and wouldn't get you points anyway, there's points available for that. So you have to be careful about overstuffing your portfolio with every single audit you've done, every single presentation you've done since the age of 3. There's no need for that. You have to show your best evidence, keep it concise, keep it neat, and you get rewarded for that. Okay. So that's what the portfolio entails. Does anyone want to ask any questions about that before I go through? Okay, there's a few on the chat. Let me have a look. There's Susan's Foundation. Okay, so on the Royal College website, it says to use an ISI, you have to have training on how to use it or be supervised with someone who has it. Is there a way to get this training? Yes, there is. So in London every year at the Royal College of Ophthalmologists, they run a course called the Basic Surgical Skills course. It's targeted at foundation level doctors, and it gives you a basic understanding of ophthalmic surgery, how to do corneal suturing, but importantly, it gives you access to their ISI machine and how to use it. So if you're in London, if you're going to be a London trainee in your foundation years, then that's what you can sort of go through and use and get your 4 hours done that way. Otherwise, what you have to do is you have to approach an ophthalmic registrar within the region that you work and ask who their simulation lead is for the region. And they're the person who can give you access to the ISI machine and let you come and use it in your off time. Typically, you don't need to be supervised to use it. So I've never had a situation where me as a F2 doctor or a foundation level 1 doctor, I've never had someone standing next to me while I use the machine to do my training, except for the first time when I was being set up and just showing the basics on how to do this and that. Otherwise, all of my training I've done on it has been independent in my own time and on my own. So just bear that in mind as well. Is there any way to get ISI training? Again, yeah. So it's basically that you have to approach the simulation lead for ophthalmology in the region that you're training in. Slides with you. I don't mind. Again, like all of this will be on the Royal College website. Sorry, on the 17 website. There's nothing original here, but I'm very happy to if that would be helpful. Okay, so that's a portfolio section done. Again, very happy for you to write any questions that you want me to clarify in the chat, and we'll have a good go through that at the end. So interview. So how do you get an interview? So number one, like we said, you have to score in the top 300 in your MSRA to be eligible. But what happens then is that you score top 300, great. Then the college will invite you to upload your portfolio. So then you upload your portfolio, and then the consultants will go through your portfolio and they will score them. And you have to get at least 40% of the portfolio marks to even be eligible for the interview. Okay, so there's another hard stop there. So if you don't get 40% of your portfolio marks, that's it. Sorry, try again next time. The interview, it's virtual. It has been virtual for at least 3 or 4 years. My cohort was the last one to be face-to-face interviews. It's 2 components, each of them lasting 10 minutes. Your first interview is a medical consultation with an actor, focusing on clinical knowledge. So you'll be presented with a case, it may be ophthalmic, it may be non-ophthalmic in nature. So it might be a patient who comes in with symptoms and signs suggestive of stroke. And you have to take history and give a management plan. The second interview will be a medical consultation, again with an actor, and that's focusing on a difficult communication or an ethical situation. So that might be an angry patient, a difficult patient, a child. It might be breaking bad news. It may well be, explaining to someone that you've operated on the wrong eye or you've done the wrong operation. So it's your ability to work through a difficult situation and show off your communication aptitude. Now, amongst the interview scores, you have to score at least 40% on your interviews to be appointable. So appointable means that you've ticked all the boxes, you're good enough to be on the training program, but there have to be enough places for you to be on the program, right? So then it'll just be ranked according to the highest scores to the lowest scores if you're appointable, and then they give out the spaces that way. So you might be appointable, but you might not get a training post. So we've talked about this briefly already, but what can you do now? So for everyone in this chat, think back, consolidate your research. Have you got any research pending? Have you got any sort of audits here that were good quality that didn't really go anywhere that you might think, oh, I could write that up and send that to be published somewhere? Do it now if you can. Building your teaching portfolio. So when you're a foundation doctor, think about, are there any sort of organizations within your hospital dedicated to medical school training, medical school teaching on the wards, bedside teaching, that sort of thing. If not, make one yourself, do it yourself and contact the medical school through, any med students you might know and organize it, you get more points for that way. If you're a medical student and you're interested, sit the Duke Elder exam. That's the main thing you can do as a medical student that you then can't do once you qualify. You can only sit this exam as a med student. So sit the Duke Elder exam, see if you can get in that top 10%. That's 2 extra points in your portfolio. Brilliant. Again, for the medical students, organize your elective in ophthalmology and try get as much out of it as you can in terms of getting to grips with using a slit lamp, examination skills, history taking skills, because that all sort of comes across when you start your training. It's a very steep learning curve, so as much as you can get in before you start will be the best. So get a feel for using the slit lamp. If you are able to, in your foundation year jobs, to get an ophthalmology job, brilliant. If you can, then try and spend a lot of your time, if you can, in clinics, in eye casualty, observing and then taking your own room and then seeing your own patients yourself and getting advice from the registrars. The SD1 who starts in ophthalmology on their day one are no better at examining a patient than the F2 starting day one in ophthalmology. So if you take that sort of into mind, there's no reason why you can't be independently seeing patients at the end of 3 or 4 months placement. So work with that goal in mind. If you have a placement in ophthalmology, get your 10 sessions signed off naturally. Approach someone who can help you with presenting case reports and publications and posters, presentation, whatever, and then get that all ticked off. And then keep your evidence safe. Everything is digital now. You don't provide a paper portfolio. It's all done online via PDFs. Keep a cloud storage system, put it on a hard drive, have it in 3 places, keep your evidence safe, keep backups. Don't let anything go missing, label it well, make sure you keep track of what you have and what you don't have. And it makes your life a lot easier because you only get a 5-day window to upload your portfolio when it comes down to it. And you don't want to be scrabbling at the last moment to get a letter from a consultant to say you did the audit or trying to find the attendance certificate for that conference you went to 2 years ago. So keep everything together, very well labeled and organized, and it makes life a lot easier. Okay. So very happy to take any questions now. If you want to pop it in the chat or just unmute yourself, just ask me in person. I don't mind whichever one. I'll just do the questions in the chat first, if that's all right. So how do we get involved in ophthalmology projects as a medical student? It's not the easiest thing in the world. There are a few ways. Number one is if you have an ophthalmology training block as part of your medical school rotation, you can always approach your registrar at that point to do something. The issue with projects is often that it's patient data sensitive and you need to be in the hospital with logins and access to the systems in order to do a lot of this stuff. So if that's a realistic possibility, for example, you might be rotating within ophthalmology in a hospital where you already have IT access, and you're going to be there for several weeks to months, then that's a very possible sort of thing to do. The second way to do it is to do a selective component in ophthalmology. So if your medical school has an option to do an SSC for 6 weeks or whatever in whatever specialty you want to do an ophthalmology and then approach someone and get involved that way. Third way is through your elective. So you can work with someone locally to get something done at that point, to get something published. When I went for my elective, I submitted an essay to the Royal College because they had prize essays going at the time. Didn't win anything out of it, but it was something that I could, I could try and do, and that's something that you guys could try and do as well. There are always these sort of opportunities going. You just have to keep an eye out for them. Yeah, there's the main reasons, like ways I can think of how many points would you need to get on average to have a good portfolio? Impossible to say. So when I applied, I think I scored in the region of 65% of the available points, which was probably average, I think, for the time that I applied. But I applied when the competition ratios was 6-1, they're now 10-1. So what I would have to do today to get into ophthalmology training, I'm not sure. So the times are changing, and you just have to do the best you can when it comes to that sort of thing. When you're referring to providing feedback from foundation trainings, as referred to tabs, yeah, it's basically a tab. So they call it different things at different stages of training, and in foundation training it's called a tab, in higher specialty training it's called an MSF. When you get to a consultant, they call it 360. It's all the same thing. So if you need to provide multi-source feedback from the multidisciplinary team, and submit that in your portfolio. If it's the case that you're not in foundation training and then you're applying, say you're doing F3, F4 year, and you want a more up-to-date thing, then that's something that you arrange yourself. You might call it something different, but at the end of the day, it's still multi-source feedback. How training programs dealing with limited number of surgical cases, like cataracts? Yes. So this is what I was alluding to before. So at the moment, I'll give you some context. So before COVID, a cataract operating list on the NHS was anywhere from 5 to 8 patients per list. So morning list, you do 5 to 8 patients, afternoon 5 to 8 patients. After COVID, we struggle to do more than 3. And there's a variety of reasons for that. Number one, the private sector in ophthalmology has exploded over the last few years. And they essentially subcontract out cataract work from the CCG. Your local region will be paying these independent providers to provide high volume cataract lists. Now, the issue is that this hoovers up all of the straightforward cases that would otherwise be coming to hospitals, which would be good for trainees, and they will reject cases which are either too complex or too frail to come onto a high volume cataract list. So what we're left with in hospitals is a lot of very challenging cataracts to do, which means that our capacity is down, and it also means fewer training opportunities for the trainees. Because ideally, if you're an SD1, you don't want your first cataract to be the most complex thing on the list. What that's meant is that in order for us to get our numbers and our training, we are now being sent to independent sector providers to get our cataract training. It's a difficult thing to do in terms of indemnity, legality, and quality of supervision, because not all the consultants operating privately are NHS consultants or have ever been NHS consultants. So quality is something that is variable in terms of training ability. And also they have to balance the fact that a trainee who is going to be slower at operating is coming onto a high volume list. So for junior trainees, it's very difficult to get much out of it. But realistically, it's the only way that we're going to be getting our numbers going forward, because the NHS cannot provide us with adequate numbers at the moment. But who knows? Let's see how things go. Are there any other routes other than the traditional? What about Caesar? Yeah. Okay. So there were always 3 routes into becoming an ophthalmology consultant. So you get your run-through training program as an ST1. You could apply as an ST3 and then join the training program late and then finish and become a consultant, or you could Caesar. Now, they've removed ST3 entry as of last year or the year before, maybe. So there's no longer an ST3 entry available. That sort of application was designed for people who've done lots and lots of ophthalmology in the past. Perhaps if they come from abroad, and they've got lots of experience and they want to apply onto the training program, but not have to do the entire training program and qualify as a consultant. But they've removed that now. So you can only apply to ST1 ophthalmology if you have less than 18 months of experience in ophthalmology. So it basically eliminates most people who have got years and years and years of experience. They're not eligible to apply into ST1. So if you have more than 18 months of experience, then you have to Caesar. So Caesar is a pathway by which you get accreditation and a CCT, so your consultancy, a badge to say you're a consultant and you're on the specialty register on the GMC, but you have to basically do it all yourself. It's DIY. So no one's going to organize placements for you. No one's going to organize your theaters. You don't rotate. You have to still sit all your exams. You have to provide evidence like a portfolio of everything that you've done and make sure that it ticks off against the Royal College's requirements for you to qualify. So it's a much longer and much more arduous process to go through a Caesar than to go into training. Having said that, you don't have to apply to be a ophthalmology SHO or trust grade in a trust. You just have to show that you've got the experience and that you can do the work. And then people build up from there. And it might take 10, 15 years, but people do it and they can Caesar and become a consultant without ever having to apply to the training program. But naturally, the advantage of the training program is that it's a laid out roadmap for you. You have supervisors, you have dedicated theatre training time, you rotate amongst all the different subspecialties that you need. So it's there for you, but you have to compete with 9 other people to get your spot. Okay, so that's what you're contending with. Okay, so that's all the chat questions. Is there anyone on who wants to ask in person or type anything else? Otherwise, any ophthalmology journals you'd recommend to aim to publish in? Yeah. So the main one I'd say in the UK is EYE. So that's run by the Royal College itself. You've got the British Journal of Ophthalmology, BJO. You could even publish to like BMJ, so the British Medical Journal. If you've got things like case reports and single case reviews and things like that, you can still publish to that. But otherwise, everything else is very much subspecialty related. So unless you're doing strabismus or pediatric ophthalmology or vitreoretinal, then there's no point submitting to those very specific journals. So BJO or probably the BMJ are probably your best bets. There are lots of these sort of international journals that are like technically accredited and they'll publish anything, but you often have to pay them a lot of money to do that, and it's in my opinion it's a bit of a scam. And sometimes the Royal College will turn around and say, actually, we don't recognize this journal and we won't accept your publication. So it's you just got to be a bit careful about where you submit to, and make sure that you don't get charged thousands of pounds to submit something. That shouldn't happen. Okay. If you don't have enough medicine experience in FY2, of course. So I'm assuming your question means enough experience in terms of what do you mean? In terms of ophthalmology experience, and in terms of have you finished your foundation year? Can you just clarify that for me?
Hi, sorry. I'm supposed to. Yeah, I was just asking, like, if you don't have enough experience in medicine, like while you're, as SHO or FY2. So
Mm-hmm.
if I haven't done like enough medicine specialty, so
It doesn't matter. It doesn't matter. So everyone, so what you have to remember is that your foundation years are not there for you to become a subspecialist. You're there to learn generic skills in medicine, surgery, and community care.
yeah,
So those generic skills will be covered by your curriculum set in your foundation year. So whatever subspecialty you do, whether it's surgery or psychiatry or GP or emergency care, you'll be learning what you need to at the level of a foundation doctor. but no one's going to pull you up on it and say that, oh, you haven't done this specialty, or you haven't done this procedure, or you haven't done ophthalmology, therefore you can't apply. If you've, as long as you've completed FY2, you've got your ARCP outcome for FY2 to say that you've passed and everything is fine. That's all that's required from that point in terms of eligibility for application. Now, naturally, it does help, in terms of your portfolio, if you've had an ophthalmology job and you can get involved from that point of view, or if you've had a surgical job and you've, had experience in theatre and, you've you've got a surgical mind and you can show some competency based on that. That always helps, but it's not essential. I didn't have an ophthalmology job as a foundation doctor. There were none available in my region. So I found workarounds for it and did it that way. Um, so so you can do all these things without having, the perfect set of circumstances in front of you. So I wouldn't stress too much about it either.
Thank you. My other question I wanted to ask was, which MCQ bank would you recommend, to prepare for the Metaro exam?
Well, no financial disclosures. Um, Personally, I use, what did I use? PassMed probably. Yeah, same thing I use in med school. They've got a decent question bank. Um, Did I buy a book? I don't think I bought a book. There's an SJT book floating around on Amazon somewhere that sort of takes you through how to approach those questions. But again, it's common sense, a lot of it. So you sort of read it and think, yeah, why did I have to pay £30 to understand that? But if it's something that you've always struggled with or couldn't get the conceptual thing about what they're asking in SJT, that's a useful resource to have. Um, I'm sure there's a million question banks out there now. Past Test must do one. There's QuesMed as well, which I'm sure has probably got an MSRA bank. It's become such a massive exam that I think everyone's sort of piling on and getting a piece of the action. So you've got choice out there, but that's ultimately up to you which one you pick and or do them all. If you've got time and the money to do it, why not? Um, Great. For evidence of an opt-out elective abroad, is it just a letter that's signed and stamped? Yeah. So what I did was I got a official letter-headed letter typed up, which has that this particular so Adam Marmel did a 6-week elective between the dates of this and this at this hospital in this specialty in this country sort of thing. And then what I did was I got them to write out the range of things I was doing. So he attended clinics and operating theatre, went on community sort of things, went on refractive camps, all that kind of stuff. I wrote like a little paragraph there to say detailed what I did. Got a signature from one of the higher ups in the hospital and a stamp. I think that's probably good enough if you can manage that. Um, yeah.